If you're taking Amlodipine, Losartan, or Lisinopril, here's the truth almost nobody tells you. These pills rarely hurt people on their own. What hurts people is not knowing what their own body is trying to say back to them. I'm Dr. Ethan Kent, cardiologist, and today I'm walking you through 8 things you need to know if you're on one of these 3 blood pressure medications.
Before we start, hit that subscribe button, because this channel is built for people who want real answers, not rushed 5-minute doctor visits. And stay with me until the end, because the last thing I'll share explains something strange. 2 people can be on what looks like the same kind of blood pressure pill, yet have 2 completely different experiences. Once you understand why, a lot of confusing symptoms suddenly make sense. Now, let's be clear about something first. This is not an attack on these medications. Amlodipine, Losartan, and Lisinopril save lives every single day. But they don't all work the same way inside your body, and that matters more than most people realize. Amlodipine works by relaxing your blood vessels directly, giving blood more room to flow. Losartan and Lisinopril work differently. They act on a hormone system that controls both your blood pressure and your kidneys. That one difference is the reason your warning signs might look nothing like your neighbors, even if you're both on blood pressure medicine. So let's start with the foundation everything else builds on. Think of your blood pressure like water moving through your house. There are 2 ways to control how much pressure builds up in the pipes. You can change the width of the pipes themselves, or you can change the signal that tells the whole system how hard to push. Amlodipine works on the pipes. Your blood vessels are not stiff, hollow tubes. They have a layer of muscle in their walls, and that muscle can squeeze tight or relax wide. When those muscles squeeze too tight, blood has less room to move, and pressure builds up, just like pinching a garden hose. Amlodipine tells those muscles to relax and loosen their grip. The vessels open up, blood has more space to flow, and pressure comes down. It is a direct physical fix, like widening a pipe. Losartan and Lisinopril work somewhere else entirely. They do not touch the pipes. They touch the control panel. Your body has a hormone system, mainly involving your kidneys, that constantly senses your blood pressure and salt levels, then sends out signals to raise or lower pressure as needed. One key hormone in this system is called angiotensin. It is powerful. It tightens blood vessels and tells your kidneys to hold on to more salt and water, both of which raise pressure. Lisinopril blocks an enzyme your body needs to make angiotensin in the first place. Losartan works a step later. It blocks angiotensin from attaching to its receptor. So even if the hormone is present, it cannot deliver its message. Different method, same basic goal. Lower the signal that raises your pressure. Here is why this matters to you. Amlodipine is changing something physical, the width of your vessels. Losartan and Lisinopril are changing a chemical signal that also touches your kidneys, your potassium levels, and other hormone pathways. Because they are working on different parts of the system, they can also create different side effects in different places in your body. That is the piece most patients are never told. Once you understand which part of the system your pill is touching, the pipes or the control panel, the warning signs I am about to walk you through will make a lot more sense. Let me introduce you to Frank. Frank is in his mid-70s, and if you want to find him on any given afternoon, check his garden first. He is out there almost every day, tending tomatoes, pulling weeds, moving bags of soil around like a man half his age. A few months after starting Amlodipine, Frank noticed something odd. By evening, his ankles and lower legs looked puffy.
He pressed a finger into his skin near his ankle, and it left a small dent that took a moment to bounce back. Frank's mind went straight to his heart. He assumed the swelling meant fluid was building up because his heart was struggling to pump properly, a classic sign of heart failure. Worried, he did what a lot of people do. He quietly stopped taking his amlodipine on his own without calling his doctor first.
Here is what Frank did not know yet. This kind of swelling is actually one of the most common and well-documented effects of amlodipine, and it usually has nothing to do with heart failure at all.
Remember the pipes from before? Amlodipine relaxes and widens blood vessels, especially small ones in your legs. But there is a catch. It relaxes the arteries more than it relaxes the veins, bringing blood back up. That mismatch lets a bit of fluid seep out of the widened vessels and settle in the tissue around your ankles and lower legs, especially after a day of sitting or standing, like Frank does in his garden. This is called peripheral edema, and doctors see it often in people taking amlodipine. It is not fluid overload from a struggling heart. It is a local, mechanical result of how the medication opens up blood vessels in your legs. The problem is not the swelling itself. The real danger is what Frank did next, stopping his medication without medical guidance, which can cause blood pressure to swing back up unpredictably. That decision, made out of fear rather than facts, is exactly the kind of moment this video is meant to prevent. Knowing the difference between a known, manageable side effect and a true emergency sign can change how you respond. And in Frank's case, it will change what happens later in his story. Now let's meet Diane. Diane started on Lisinopril a few months ago, and not long after, she developed a dry, tickly cough that would not go away. No mucus, no fever, just a persistent urge to clear her throat, especially at night when she was trying to sleep. She figured it was allergies. It was spring, after all. She bought cough drops, tried an allergy pill from the pharmacy, and even switched her laundry detergent, thinking dust or fragrance might be the trigger. Weeks passed and nothing helped.
What Diane did not know is that this cough is one of the most well-known effects of lisinopril, and it comes down to one specific compound in your body called bradykinin. Remember that lisinopril blocks the enzyme your body uses to make angiotensin, the hormone that raises blood pressure. Here is the catch. That same enzyme also happens to break down bradykinin, a different compound involved in inflammation and airway sensitivity. When lisinopril blocks the enzyme, angiotensin goes down, which is exactly what we want, but bradykinin builds up as a side effect. That extra bradykinin can irritate the lining of your airway, and for some people, that irritation shows up as a dry, nagging cough that lingers for weeks. This is not dangerous. It will not damage your lungs or your heart, but it is uncomfortable, disruptive to sleep, and easy to mistake for allergies, a cold, or even something environmental, exactly like Diane did. Here is the important part for you. This cough is specific to ACE inhibitors like lisinopril. It does not happen with amlodipine, and it is much less common with Losartan, because Losartan works at a different step and does not raise bradykinin the same way. So, if you are coughing and you are on lisinopril, that connection is worth mentioning to your doctor, instead of assuming it is something else entirely. Sometimes the fix is as simple as switching to a different medication in the same family, one that lowers blood pressure without touching that same pathway. Here is one that deserves your full attention, because this is where a normal side effect can cross into something serious. All three of these medications, amlodipine, Losartan, and lisinopril, can cause a drop in blood pressure when you stand up quickly. Doctors call this orthostatic hypotension. In plain words, it means your blood pressure dips for a moment because your blood vessels have not adjusted fast enough to gravity pulling blood down toward your legs. For most people, this shows up as a brief, mild wave of lightheadedness. You stand up from a chair or get out of bed, and for a second or two, the room feels a little foggy, or you feel briefly unsteady. Then it passes, and you go on with your day. This mild version is common, especially in the first few weeks of starting a new blood pressure medication, or right after a dose increase. It is your body adjusting to a lower baseline pressure. But here is where you need to draw a clear line in your mind. There is a big difference between a brief, foggy feeling that clears in a few seconds and true fainting or a fall. If you ever actually lose consciousness, even briefly, or if you feel so dizzy that you have to grab furniture or a wall to keep from falling, that is not a normal adjustment anymore. That is your blood pressure dropping low enough to put you at real risk of injury, especially for older adults, where a fall can mean a broken hip or a head injury. So here is a simple rule to carry with you. Mild, brief dizziness that passes quickly, especially early in treatment, is common and usually not an emergency. Fainting, near fainting, or an actual fall is different. That needs a call to your doctor, and depending on how it happened, it may need urgent medical attention the same day. One more tip worth remembering. If you ever feel that lightheaded sensation coming on, do not just push through it. Sit back down immediately, or hold on to something sturdy nearby. Standing up slowly, especially first thing in the morning, gives your blood vessels time to catch up, and it is one of the simplest ways to lower your risk of a dangerous fall. Now let's talk about something you cannot feel, but that matters just as much as anything on this list. If you are on Losartan or Lisinopril, your body needs regular blood tests, specifically checking two things: your potassium level and your kidney function. Remember, both of these medications work on that hormone control panel we talked about earlier, the system that also manages your kidneys and your salt balance. Part of how they lower blood pressure involves your kidneys holding on to slightly less sodium and slightly more potassium than usual. For most people, this shift is small and harmless. But in some people, especially those with existing kidney concerns, older age, or those also taking potassium supplements, this shift can push potassium levels too high. That condition is called hyperkalemia, and it can affect your heart rhythm if it climbs too far without anyone noticing, because you usually cannot feel high potassium until it becomes serious. At the same time, these medications also change blood flow through your kidneys. For most people, that adjustment is safe and even protective long-term. But your doctor needs to confirm your kidneys are handling that adjustment well, especially in the beginning. This is why blood tests exist. And here is the part I want you to write down. Ask your doctor for two specific things at your next check: a potassium level and a kidney function panel, which usually includes something called creatinine and eGFR. These numbers tell your doctor exactly how your kidneys and your potassium are responding to the medication. This matters most in the first few months after starting Losartan or Lisinopril, or after any dose increase, because that is when your body is doing most of its adjusting. Once your numbers look stable, your doctor may only need to check occasionally after that. Amlodipine, by contrast, does not typically require this same kind of monitoring because it does not work through this hormone pathway. That is one more example of why knowing which category your medication falls into changes what you should actually be asking your doctor at your next visit. Let me tell you about Ruth. Ruth is the kind of patient every doctor wishes they had: careful, informed, and proactive about her health.
When her doctor mentioned cutting back on sodium, Ruth took it seriously. She went to the store and bought a salt substitute, the kind sitting right next to the regular salt, thinking she was making a smart, healthy swap.
What Ruth did not realize is that most salt substitutes are not simply low-sodium salt. They work by replacing sodium chloride with potassium chloride. That is exactly the ingredient that raises your potassium levels. And Ruth was already on Losartan, a medication that raises potassium on its own. Without knowing it, Ruth was stacking two potassium-raising forces at the same time, one from her medication and one from her well-intentioned salt swap. She was doing everything she thought was right, and that combination was quietly pushing her potassium higher than either factor would on its own. This is a trap that catches careful people specifically because it looks like a healthy choice on the surface. If you are on Losartan or Lisinopril, check the label on any salt substitute before using it regularly, and mention it to your doctor, especially if you are already having your potassium monitored.
There is a second trap worth knowing about, and it involves something in almost every medicine cabinet: ibuprofen and similar pain relievers, known as NSAIDs. These are common, easy to reach for, and often used without a second thought for a sore back or a headache. But NSAIDs can quietly work against Losartan and Lisinopril in two ways. They can blunt how well the medication lowers your blood pressure, and they can add extra stress to your kidneys, especially when used regularly rather than just once in a while. Neither of these traps means you can never use a salt substitute or take ibuprofen again. It means both deserve a quick conversation with your doctor first, so you know what is safe for your specific combination of medications, rather than assuming that a healthy label or a familiar pill on the shelf is automatically harmless for you. Let's bring this together into one simple framework you can actually remember. Instead of thinking of these three medications as one big group called blood pressure pills, think of each one as having its own fingerprint, its own specific pattern of things to watch. If you are on Amlodipine, your main things to watch are swelling, especially in your ankles and lower legs by the end of the day, and something we have not covered yet, gum changes. In some people, amlodipine can cause the gums to slowly thicken or grow slightly over the teeth, a condition worth mentioning to your dentist if you notice your gums looking different than before. Both effects come from the same root cause, its action on blood vessels and tissue, not a sign of heart or kidney failure. If you are on Lisinopril, your two things to track are a dry, lingering cough and your potassium and kidney labs. The cough is uncomfortable but not dangerous. The labs matter because they catch changes you cannot feel on your own. If you are on Losartan, drop the cough from your list, since Losartan rarely causes it. But keep the same focus on potassium and kidney labs, because Losartan shares that same hormone pathway with Lisinopril. Now, back to Frank. After stopping his amlodipine on his own, Frank eventually called his doctor, worried and confused about what was happening in his body. His doctor explained calmly that his ankle swelling matched a well-known, common effect of the medication itself, not a sign that his heart was failing. Together, they adjusted his approach. Some doctors lower the dose, add a small change in timing, or pair it with another medication to offset the swelling, rather than stopping treatment altogether. Frank went back to his garden, back on a plan that kept his blood pressure controlled, this time with a clear understanding of what his body was telling him. And that brings us to the single most important truth in this entire video. These three medications do not fail the same way. They do not warn you the same way, and they do not need the same follow-up. Amlodipine speaks through your legs and your gums.
Lisinopril speaks through your airway and your labs. Losartan speaks mainly through your labs alone. Simply taking your pill and hoping for the best is not enough. Knowing your specific medication's fingerprint, what it does, and what it is quietly capable of, is what actually protects you long term. Not fear, not guesswork, just clear understanding.
Now, let's cover the signs that need immediate action. Not a phone call tomorrow, but emergency care right now. Watch for any sudden swelling of your face, lips, tongue, or throat. This is called angioedema. It is rare, but it is serious, and it is linked most strongly to ACE inhibitors like lisinopril. If your throat feels tight, your tongue feels swollen, or your voice suddenly changes, call 911 immediately. Do not wait to see if it gets better on its own. Watch for severe dizziness that leads to actual fainting, or a fall you cannot explain. As we covered earlier, brief lightheadedness when you stand up can be normal. Losing consciousness is not. That needs urgent medical attention the same day. Watch for a heart rate that feels unusually slow, especially paired with weakness, confusion, or shortness of breath. If you check your pulse and it feels far slower than normal for you, along with feeling unwell, that combination needs medical attention right away, not next week. And watch for an inability to urinate or a sudden, significant drop in how much you are urinating. Since these medications interact closely with your kidneys, a sudden change like this can signal that your kidneys need immediate evaluation. None of these signs are common. Most people take these medications for years without ever experiencing any of them. But knowing them means you will recognize the real emergency instantly, instead of wasting precious time wondering if it is something to worry about. Now, before you go, I want to leave you with this. Everything we covered today is not a reason to fear amlodipine, losartan, or lisinopril. These medications are proven, they are effective, and for millions of people, they are quietly preventing strokes, heart attacks, and kidney damage every single day. This video was never about scaring you away from your treatment. It was about making sure you understand it so you can work with your doctor as an informed partner, not someone just following instructions blindly. So here is what I want from you. In the comments, tell me which of these 3 medications you are taking, amlodipine, losartan, or lisinopril, and how long you have been on it. If this video helped you understand your own prescription a little better, share it with someone you love who is taking one of these too. It might be the conversation that helps them ask their doctor the right question at their next visit. I'm Dr. Ethan Kent, and I will see you in the next one.